Hello everybody, I am Dr. J Lakhani. I am a consultant endocrinologist working in Ahmedabad, and here today we are going to discuss assessment of insulin secretion and insulin sensitivity. Now before we begin, you had heard about unifying theory in physics. There's also a unifying theory for diabetes. So whether you're talking about type 1 diabetes or type 2 diabetes or MODY or any form of diabetes, at end of the day, diabetes is an imbalance between insulin secretion and insulin resistance. So when insulin secretion cannot match with the insulin resistance, you develop diabetes mellitus. Now, for example, in type 2 diabetes, you have higher insulin resistance and then you have lower insulin secretion. So hence, there is an imbalance and you develop type 2 diabetes. But in type 1 diabetes, you have normal insulin resistance, but you have lower insulin secretion. Again, there is an imbalance and you have type 1 diabetes. So at end of the day, type 1 diabetes and type 2 diabetes and any other form of diabetes for that matter is an imbalance between insulin secretion and insulin resistance, and hence this is a unifying theory for all forms of diabetes. And hence it is very important for us to understand the science and the biochemistry behind insulin secretion and insulin resistance, so that we are able to understand our patients better and we are able to conduct better research. Now first let's talk about insulin resistance. So how do you assess insulin resistance? Now a lot of these things which we are going to discuss, they are very important from a research perspective. They are very important for endocrinologists to really study their patients in more detail, for pharmacologists to develop new drugs, for researchers to look at epidemiological aspects of diabetes. However, a lot of these are not very important in clinical practice. Now, some aspects of this are very important in clinical practice, whereas most of these are more important from a research perspective. So what we're going to do is we're going to discuss both what is important for clinical practice as well as what is important for research, and it's going to be intertwined amongst each other, but I'll point out what is important and where we should give more focus to what. So to give you a one slide summary about insulin resistance, the various tests that we do for insulin resistance have very limited use in clinical practice. So at end of the day, what are you really going to gain at an individual patient level by assessing their insulin resistance? Not much, right? The only the advice what you're going to give to your patient is to a pre-diabetic individual with obesity, what you're going to ask for is basically exercise, diet, perhaps metformin, right? But whether you do it with expensive investigations or whether you do it by clinical judgment, it really does not matter. So for an individual perspective, it has very limited use, but from a research perspective, it is very, very useful. So for all practical purposes, clinical examination and surrogate markers are very useful. So this is what should be focused on, and we are in the next few slides also going to discuss the clinical aspects of insulin resistance. But the gold standard, which is mainly used in research, is the hyperinsulinemic euglycemic clamp. So the clamp studies are the one which are used mainly for research purposes, and these are considered to be gold standard for assessment of insulin resistance. So overall, if you talk about assessment for insulin resistance, it can be done in two major ways. One is the direct methods and the indirect methods. The direct methods include what we talked about, hyperinsulinemic euglycemic clamp. You can use an insulin suppression test and insulin tolerance test. On the other hand, you have indirect methods like clinical markers, which we are going to discuss, insulin indices, which form a major chunk of today's lecture, and certain surrogate clinical and biochemical markers of insulin resistance. So let's first talk about the direct methods for assessment. Now, the most frequently used method mainly in research labs is what is known as hyperinsulinemic euglycemic clamp. Now, this is considered to be the gold standard for assessment of insulin resistance. Again, I reiterate that at individual patient level, this is not generally very useful, but very useful for research. Now, Dr. Ralph DeFronzo, who is one of the pioneers in diabetes therapeutics, is one of the people who actually proposed this clamp studies long time back. So these clamp studies have a lot of importance, but mainly more of historical importance and research importance rather than clinical practice importance. So what you do in a hyperinsulinemic euglycemic clamp, as the term suggests, it is euglycemia. So you are trying to maintain a steady level of glucose. So you give first you give an insulin infusion. So instead of giving glucose first, you give an insulin infusion first, and this is done to block the hepatic gluconeogenesis, right? So you block the hepatic glucose production, then the glucose infusion is given, and it is adjusted to maintain a steady state of plasma glucose. Now, when the hepatic glucose is suppressed, the amount of glucose given from outside, what you are giving exogenously to maintain euglycemia, is the amount of glucose that goes into the muscle. Now, if you require more glucose to maintain euglycemia, that means that more glucose is going to the muscle, which means that patient has higher insulin sensitivity and lower insulin resistance. However, if you need less glucose, it means that less glucose is going to the muscles, which means you have more insulin resistance. So it is exactly the opposite. So basically, what you are doing is you are clamping the hepatic glucose output, and then you are maintaining a steady state of glucose level. So to interpret the results, typically, remember, the higher the glucose infusion rate means that you have higher sensitivity and less resistance, and vice versa. So if you have glucose infusion rates of more than 7.5, it is considered to be normal. 4.5 to 7 is variable, and less than 4 would be considered to be insulin resistance. Now the next is insulin suppression test. Now insulin suppression test, remember the old dictum in endocrinology. Whenever a hormone is thought to be in excess or thought to be high, we try to suppress it. If a hormone is found to be low, we try to stimulate it, right? So that's the typical dictum we use. For example, let's say in Cushing syndrome, we are suspecting the cortisol to be high, we try to suppress the cortisol. In Addison's or adrenal insufficiency, we are thinking that the cortisol is low, we are trying to stimulate the cortisol level. So in the same way, when you are thinking about insulin resistance, you're thinking that the insulin levels are high, you will try to suppress the insulin level. So that's what is basically done in an insulin suppression test. You can use different agents for suppression of insulin. Typically, currently, what is used frequently is octreotide. So you can use octreotide to suppress the endogenous insulin production. And now the insulin infusion and glucose infusions are given, and the dose is adjusted to achieve again a steady state of plasma glucose concentration. So the steady state is achieved, the higher the glucose required to achieve the steady state, higher the insulin resistance. So this is the insulin suppression test. Then you have, of course, insulin tolerance test. Now, insulin tolerance test is completely outdated, right? I'll not discuss this in too much detail, but I don't think this is going to be very useful in clinical practice at all. The only question you have to ask is, would you like to produce hypoglycemia in your subject to assess for insulin resistance? That's the only question you need to ask yourself. And if your answer to this is no, then don't do this test, right? This test is not recommended in current era. It is a more or less outdated test. So basically what you do is, after an overnight fast, you give a bolus of insulin to the patient, and this will reduce the glucose level to about 50%, and sometimes may even provoke a frank hypoglycemia. Now, if the patient has a peripheral insulin resistance, you will require higher insulin resistance means you will require more insulin to produce hypoglycemia. Lower insulin resistance means less insulin is required. It's a very simple concept to understand, but it is extremely dangerous to perform. So hence, perhaps this is not a test which you should perform in day-to-day practice. Then let's talk about the indirect methods for assessment of insulin resistance. Now here, the frequently used and perhaps I would say frequently abused are the insulin indices, right? Now these are very simple to calculate, simple tests to perform, little bit expensive, and in individual cases not very useful, right? So this is something, a very controversial area. So again, a very frequently used test is what is known as a HOMIR. HOMIR can be simply tested by checking the fasting insulin level multiplied by the glucose level divided by 22.5 if you're using it in millimoles, and if you're using milligram per deciliter like all of us do, then you will divide by 405. So basically, the physiological basis of HOMA is that the relationship between glucose and insulin in the basal state reflects the balance between hepatic glucose output and insulin secretion, which is maintained by a feedback loop between the liver and the beta cell, right? So in a fasting state, the glucose is mainly produced by the liver, so that is the hepatic glucose output, and the beta cell produce the insulin to counteract this glucose which is produced, and hence you maintain a steady state, and there is a constant feedback between the two, right? So between the liver and the beta cell, there is a feedback loop which is there. So if the glucose level increases from the liver, you have more insulin production, and you have less amount of glucose, then you have less insulin production. So there is a constant feedback which is being generated. So this is the basic premises of the HOMA-IR test, right? Typically, looking at the test, and if you are performing this in prepubertal children, if the value is more than 2.5, it is considered to be insulin resistant, and in pubertal children or adults with SMR more than or sexual maturity rating more than 2 or higher, if it's more than 4, it is considered to be insulin resistant. Now, why we have put this slide actually to tell you that lot of the times this test is extremely abused in pediatric practice. I've seen a lot of pediatric children, obese pediatric children ask for HOMA-IR. In PCOS adolescents we ask for HOMA-IR. Now, practically speaking, yes, it is useful to quantitate insulin resistance, but if you find an acanthosis nigricans in your child, that's the best God-given marker for insulin resistance. You don't need a test to prove it, right? So you don't need to perform this expensive test, and the patients, the parents of the patient constantly fret over this. They constantly, lose the sleep over this. That's not important. What the child rather, you'd rather spend the time and money on better counseling for lifestyle measures rather than, spend the money on doing this test. The current guidelines also on pediatric obesity do not recommend the use of, these markers for assessment of insulin resistance, unless, of course, you are doing it in context of a research study. Then you have HOMA-2. So the issue with HOMA was that, the HOMA originally was developed for insulin assays based on RIA, but now you have better assays, you have different assays, you have immunological assays for insulin and other assays which have been developed. So hence the HOMA model had to be revamped. So this is a new model which is a computer generated model. So this version actually incorporates the estimation of proinsulin also into the model, because now we realize that there's a lot of the insulin which is detected is actually proinsulin. So it also counters this into account. It also takes renal glucose losses also into account. So it's an updated model, and now you have also C-peptide can be used in place of insulin as a marker. So you have this HOMA-2 which is available. This is available from the Oxford's website. I've given a screenshot of the website. You can download it. It is available as a standalone app. So you can download this app. I'll show you the app. This is an app for Mac. So this is a HOMA-2 calculator. You enter the plasma glucose value. You can use different units, and you enter the fasting insulin levels. You can again see the different units here. So it gives you the percentage HOMA beta, the percentage HOMA S, that is HOMA sensitivity, percentage sensitivity. These are very simple to understand. And then of course insulin resistance or IR. For example, I'll give an example of a patient. Let's say the fasting glucose was 90 milligram per deciliter. The fasting insulin level was 8, and in terms of microunits per ml. So the HOMA beta percentage, this is a normal patient, non-diabetic, non-insulin resistant patient. So you can see the HOMA beta percentage was 97%. The sensitivity was 96%, which is pretty good. So this patient basically is doing well, right? And the insulin resistance is 1.04, which we saw that in adults less than 4 is considered to be normal. So this is a typical example of a HOMA-2 calculator. Now HOMA beta is a assessment for insulin sensitivity. Of course, we are going to discuss in more detail about insulin sensitivity, but I thought it would be a good point to really take this point here when we are discussing HOMA anyways. So HOMA beta is calculated by 20 into fasting plasma insulin divided by fasting plasma glucose minus 3.5. Here of course you use fasting FPI in micro units per liter, and fasting plasma glucose in millimoles per liter, or micro units per ml, right? So this is the similar. So this is how you calculate the HOMA beta. Now the problem is that of course these tests are all available, but like I said, they are very useful in mainly for research purposes, for epidemiological purposes, for physiological studies, but they're not very useful for individual patient level. So where do you use HOMA? You basically use it for, you can use it in individual patient for longitudinal follow-up of the same patient. So if you do see the progressive decline of your patient, a patient's beta cell, you can use this. You can very well use this in epidemiological and cross-sectional studies, and of course you can use it in certain physiological situations. Like for example, if I want to see what is the insulin resistance in a pubertal children versus a prepubertal child, something like that, you can use it in physiological situations. Of course, there are important caveats for use of HOMA. So we remember, we do not have population and ethnic specific data. Most of this was developed from the United Kingdom, so you don't have specific data for Indian patients or South Asians. You cannot use it when the glucose and insulin levels are fluctuating. For example, if the patient has acute hyperglycemia or diabetic ketoacidosis or COVID-induced hyperglycemia, you cannot use these tests. You cannot use it for a patient who is on exogenous insulin because mainly you're using insulin levels, and of course, that will be detected. The exogenous insulin will be detected, so you cannot use it. And per se, it would not be a good idea for using it on patients on insulin secretagogues like sulfonylurea. But in selected cases, you can use it. However, you should know how to interpret those results. One very important caveat is that, remember, HOMA beta cannot be reported in isolation. This is something which a lot of endocrinologists also need to understand. HOMA beta it always has to be reported with a HOMA IR or HOMA sensitivity. The reason is that, let's say a patient is very young and fit, right, and has very low very high insulin sensitivity, very low insulin resistance. In that case, when you put the values in the calculator, you will find the HOMA beta to be lower and the insulin sensitivity to be very high. So in such a scenario, you will falsely interpret this as low HOMA beta values. This is one of the challenges, right? So whenever you give a report of HOMA beta, it has always to be given with HOMA IR. HOMA beta cannot be interpreted in isolation. This is something which labs and both the doctors also need to really understand. Then of course you have variations of HOMA. So HOMA was the original index. Then people thought, why not make it better? So then you had other variations, so you have something known as quickie. You can see the formula. I'll just quickly breeze through this. You have MCCALL index. In fact, MCCALL index includes triglyceride, which makes it a very sensible index. And I think, if you want to use anyone, of course, the formula is very complicated. You have online calculators to use it. But MCCALL index is a very sensible index because it uses other surrogate markers like triglyceride, which is a very important marker of insulin resistance. So this is the one, and in fact in clinical studies also, MCCALL index has been found to be most, has the best correlation with the clinical parameters of insulin resistance. As you can see from this study from Korea, the MCCALL index compared to other indices showed the highest accuracy in detection of metabolic syndrome as a surrogate marker of insulin resistance. So just to summarize, these are the various values which you can use for insulin indices. You can take a screenshot of this, and save it for use. But like I said, we don't use this very commonly in clinical practice. Now let's come to the clinical markers of insulin resistance. So you have, what does a patient with insulin resistance look like, right? So if you see from head to toe, the patient could have features of pseudoacromegaly. Remember, higher insulin levels will have specificity spillover on the IGF-1 receptor. Remember, the insulin-like growth factor and insulin have very similar molecular structures. So patient could look acromegaloid. You could find sometimes a newly diagnosed insulin resistant type 2 diabetes patient looks like acromegaloid. Right, so this is something you should keep in mind. Patients can have muscle hypertrophy. Acanthosis nigricans is the most common clinical presentation of insulin resistance. Patient can have skin tags, hirsutism, alopecia, oligoamenorrhea, infertility, anovulation, central adiposity, which is a very important marker. Certain patients can have lipodystrophic syndromes like lipoatrophy or hypertrophy, which are, though rare, must not be missed out. And children, of course, can have normal, impaired, or sometimes even accelerated growth. So sometimes insulin resistant children, you will find that they are taller than their counterparts because of specificity spillover and higher insulin acting on the IGF-1 receptor. Then you have surrogate biochemical markers of insulin resistance. Of course, the most important is metabolic syndrome as such. One of the reasons why we don't use insulin resistant tests is because you have the clinical syndrome, which is metabolic syndrome. We all know the definition of metabolic syndrome, so I'll not go into detail, but this is the definition. Again, those who are new to this can take a screenshot and save this for future use. There's another very useful index, which is known as a triglyceride glucose index. Now, all of these theories, like I said, I have this, one more theory which I would like to really propose. I very strongly believe that both a fasting as well as a post-meal triglyceride is a very, very strong marker of insulin resistance and also a very strong marker of future risk of developing diabetes mellitus as well as future risk of developing coronary artery disease. So, some of these young patients who come to me who have come for, their routine checkups, and they have very high triglyceride levels, typically more than 150. That is the time I start counseling them for weight loss, lifestyle measures, and so on and so forth, because these group of patients have very high risk of developing diabetes mellitus and coronary artery disease in future. So triglyceride glucose index it's very simple to calculate. You use a log of fasting triglyceride into plasma glucose divided by 2, and those with higher levels of this index have 1.16 times higher risk of developing coronary artery disease and higher risk of developing diabetes. So clinical applications, where do you consider using these markers of insulin resistance? At individual levels, you can use it for assessment of risk of developing type 2 diabetes, assessment of future risk of cardiovascular disease, and of course it becomes a very important point to initiate discussion on lifestyle measures for your patient. One more very important thing I'd like to tell you, again, going back to the triglyceride index, I very strongly believe that the features of metabolic syndrome, NASH or NAFLD, that is non-alcoholic fatty liver disease, so those patients having higher SGPT, or having on ultrasound, fatty liver and high triglyceride, all these three are often, they exist in the same patient, right? And this is the patient who has very high risk of developing diabetes. In fact, we have seen a lot of patients, we look at their past records, and young patients who come with type 2 diabetes, if you see their 1 year or 2 year reports back, they'll have this thing very common. They'll have high triglyceride levels and they'll have an ultrasound report showing a grade 1 fatty liver, and nobody took notice of this, and the patient went on to develop diabetes. So I think a good point, a very important point here is to start a discussion on lifestyle measures when you see these patients at this point of time, rather than wait for the patient to develop diabetes. And in today's COVID era, it's especially important because the same group of patients, they will often have a baseline HbA1c of 6. We had a great talk by Dr. Balram Sharma about HbA1c. Their baseline HbA1cs will be 6, but if they develop COVID and if they're giving steroids, their sugars go as high as 300. So this is something, and we know that this higher hyperglycemia is a marker for higher mortality. So this is something you should all keep in mind while dealing with these patients. How do you assess insulin secretion? So we looked at insulin resistance. Now let's look at the other end of the spectrum, that is insulin secretion. So there are, insulin is secreted in two ways. One, you have the basal insulin secretion, and then you have a stimulated secretion. Now stimulation of insulin occurs after nutrient, right? For example, glucose or carbohydrates and so on. It could be mediated by other hormones. It could be mediated, for example, glucagon stimulates insulin release, and it could be mediated by pharmacological agents, for example, sulfonylureas, right? So this is how insulin is released. Now insulin is released post-meal in two phases. One is the first phase insulin secretion, and then you have the second phase insulin secretion. Now what happens is that there are ready-made insulin granules in the beta cells. These are ready to be released, right? So these are, so as soon as the the signal comes for post-meal or glucose surge, these preformed preformed insulin granules, they immediately release the insulin. So this is the first phase insulin secretion, and then you have a recruitment of new insulin granules, and this go on to produce the second phase of insulin release. Now why this is important? Because loss, I'm repeating this again, giving focus to this, loss of first phase of insulin secretion is one of the earliest markers of diabetes mellitus, type 2 diabetes mellitus, for that matter even type 1. So the loss of first phase insulin secretion is one of the very important markers of the future risk of patient developing diabetes mellitus, and hence it is very, very important to recognize this initial loss. So why some patient, when you're talking about insulin secretion, one patient just asked me, sir, why don't we just measure the insulin levels? You have this test, insulin test, why don't we measure it? The reason is very simple. Remember, the majority of endogenous insulin which is secreted goes into the portal circulation. The insulin resistance basically impacts the levels of insulin apart from just your insulin secretion. So this also has to be kept in mind. If the patient is on exogenous insulin administration, again that will be detected. And remember, secretion is pulsatile in nature, so you will often get levels at different troughs and peaks will show different levels. So you can't just directly measure the insulin levels. So you can use a surrogate, which is C-peptide. C-peptide is basically, remember, the proinsulin is broken down into insulin and C-peptide. So there is an equimolar secretion of C-peptide. So for every for every amount of insulin that is released, there is an equal amount of C-peptide which is released. Now the good thing about C-peptide is that the amount of C-peptide release is equal to the amount of insulin release, so it's equimolar. The C-peptide is not extracted by the liver, but the endogenous insulin goes to the portal circulation, so majority of it extracted by liver, whereas C-peptide escapes this. The C-peptide clearance occurs mainly by the kidney. So this is constant, and this means at a given point of time, the amount cleared by the kidney is the amount which is being produced. And remember, the exogenous insulin does not have impact on the C-peptide. So this is the reason why C-peptide is a better marker. So how can you assess the phases of insulin secretion or the insulin secretion. Remember, all of these again have mainly historical importance or mainly importance from a point of view of research rather than point of view of in real life clinical practice. So there are three very commonly talked about tests, not commonly performed. It is hyperglycemic lamp. Remember, we talked about euglycemic lamp. This is hyperglycemic lamp. You have IV glucose tolerance test. We all know about oral glucose tolerance test. Dr. Balram Sharma talked about this also. But there is something known as IV glucose tolerance test, which is what we'll see in a minute. And then you have something known as sigma. So this is a hyperglycemic lamp, right? So first, like I said, you talked about euglycemic lamp. Now we are talking about hyperglycemic lamp. So this is a study done to assess mainly the first and second phase of insulin response. Here the patient is given an acute burst of glucose, then there is a sharp increase in the glucose. This is the sharp increase in the insulin secretion. This is the first phase insulin secretion, and this after this there is a small dip, and then there is a second steady state of insulin secretion, which is the second phase of insulin secretion. So basically you give a burst of glucose and then you at regular intervals measure the insulin secretion, either by measuring the insulin per se or measuring the C-peptide. C-peptide is a better marker per se. Original classical tests were done using insulin secretion, measurement of insulin. So this is how the hyperglycemic lamp is performed. And to give you an example, how it looks in a normal person versus a diabetic individual. In a patient with diabetes, there is basically blunting of the first phase of insulin secretion. This like I said, is a marker of early marker of development of diabetes mellitus. So in a normal individual, you can see a robust first phase and a second phase of insulin secretion. But in a patient with early diabetes, you see the first phase of insulin secretion is lost, but the second phase of insulin secretion is still preserved. And in a late diabetic individual, there's completely flat curve. So there is neither first phase nor there is a good second phase of insulin release. Then of course you have something known as IV glucose tolerance test, IVGT. Here you give rapid intravenous insulin of glucose, which produces a rapid rise in the glucose at a peak and then you measure the peak at about 3 to 5 minutes, and then it again falls back to normal. The rate of decrease at between 10 to 30 minutes after the injection can be used to define what is known as disappearance constant, which is an index of glucose tolerance. So this is again, like I said, mainly used for research purposes. There is something known as acute insulin response, which is actually useful in practice. So this is an index derived from intravenous glucose, and here there is a mean increment of insulin secretion over a baseline in the first 10 minutes. So the insulin release in the first 10 minutes is a critical measurement which is taken. This is basically same as first phase insulin secretion. But again, if you see in clinical practice, I'll show you this in a minute. Of course, you have something known as sigma, which is continuous infusion of glucose with model assessment. This is again very similar to this, but here you give a continuous infusion of glucose. So what we are basically seeing is that in patients with diabetes, you have the loss of the first phase of insulin secretion. Now, in some of these patients, you can actually use a non-glucose stimuli. For example, you can use arginine or isoproterenol, and what you see is that in the initial phases, there is loss of response to glucose, but the response to non-glucose stimuli is preserved. So again, in an early type 2 diabetics, you can see there is complete loss of insulin, first phase response to first phase insulin secretion or acute insulin response to glucose, but the response to non-glucose stimuli is preserved. So this patient is early diabetic. So eventually, in a patient with who has complete loss of beta cell function over a period of time, even this response to non-glucose stimuli is also lost over a period of time. This is very fascinating for an endocrinologist, but I'm sure in clinical practice this has very little use in day-to-day clinical practice. Now let's talk about what we use in clinical practice, and that is insulin reserve testing, and this is where the role of C-peptide really comes into picture. So here, what you can do is you can measure C-peptide in the blood directly by either measuring the fasting C-peptide. You can use a stimulated C-peptide, or you can use a random C-peptide, or you can measure the C-peptide in the urine, which requires a 24-hour urinary collection. Now, of all these, the stimulated C-peptide is the best marker of beta cell reserve. One thing you have to keep in mind, lab related issue, hemolysis can cause a degradation of C-peptide samples, so you should be very careful while handling these samples. So what are the different ways in which you can stimulate C-peptide? You can use a glucose load, you can use a mixed meal, or you can use glucagon for stimulation. You can use random C-peptide also. So one study had shown that random C-peptide is a very good test, better than fasting or stimulated for classification of diabetes. Of course, this is controversial, but having said that, it's a very good starting point. So, I've seen a lot of doctors ask for fasting C-peptide. Rather, I would say ask for a non-fasting or a random C-peptide in patients where you want to differentiate between type 1 and type 2 diabetes. How do you interpret a non-fasting C-peptide value? If the C-peptide value is less than 0.6 nanogram per ml, it is strongly suggestive. Remember, just see the units, be careful. Your lab may give different units. So 0.6 nanogram per ml is strongly suggestive of absolute insulin deficiency and strongly suggestive of type 1 diabetes. If it's less than 0.18, the patient is unlikely to achieve good glycemic control without use of multiple dose of insulin. So all practical purposes, this patient should be given a multi-dose insulin, MDI. But if it's more than 3, it is unlikely to be type 1, more likely to be type 2 or MODY. So this is something which is where a random C-peptide is very useful. Remember, another caveat before testing for C-peptide, remember that these tests should only be done for once the patient achieves euglycemia. It should not be done in patients who are having severe hyperglycemia, coming in decay, all these things. Once the things have settled down, then you can assess for this. So patients comes in a diabetic ketoacidosis. After you start the patient on insulin infusion. Once the patient settles down after a few weeks, you can perform this test rather than performing it in an acute situation. Glucagon stimulated C-peptide, now you have glucagon easily available, so you can draw a baseline sample after an overnight fast, administer 1 milligram of glucagon IV, and then after that you take samples 6 minutes and 10 minutes after giving glucagon. So you take a C-peptide sample 6 minutes and 10 minutes. If you want to take only one sample, you can just take a 6-minute sample, because most of these tests are now designed for results are designed for 6-minute sample. Then you have mixed meal stimulation test. This is something we perform in our own laboratory in our own hospital. It's very easy to do. You measure the fasting blood glucose with the C-peptide. Then you give a liquid meal, which is either Sustacall or Ensure Plus powder, 6 scoops in 200 ml of water, and the patient is asked to drink this. And after 90 minutes, you again check the sugar along with the glucose value along with the C-peptide value. Now, for a long time, these tests was not performed because you do not have Sustacall easily available. What is exactly Sustacall? Sustacall is basically a protein powder. It's nothing great, right? It's from Nestle. You have Sustacall Junior available in India, but you don't have the original Sustacall easily available. So you can use a similar composition powder, which is Ensure Plus, right? Pardon me for using brand names, but this is the reality. We have to say it, because otherwise these tests are not. It's a very easy test to perform. Unfortunately, it's not being done by a lot of people because they feel Sustacall is not available, right? So you can use Ensure Plus, which is similar composition. This is the composition. It's not very easily visible, but you can just Google this. It's found everywhere. So basically, you need to have a similar composition powder. You can use an Ensure Plus powder, which is very easily available almost everywhere. Now, what we have done, something our own personal data, but we have not published it. So, please consider this as a pre-publication, sort of an expert opinion. We are working on a study for this for quite some time. We are collecting data for that. So, what we have done is we have created a scoring system for mixed meal stimulation test. So, fasting and post-stimulation values. So, you can see if the value is less than 0.24 nanogram per ml, again, be careful about the unit. We call it grade 1F and give a score of 5. Then of course between 0.24 to 0.26, I think this is jumble here, 0.6 to 0.1 and more than 0.1, this is the scores that we give. And post stimulation, again you can see if the value is between less than 0.6, the score is 5. Again I apologize for this table being incorrectly placed. 0.6 to 1.5 score of 3, 1.5 to 1.8 score of 2, and 1.5 to 3.3 we give a score of 1. If it's more than 3.3, it is considered to be normal, and we do not give any score or score of 0. So in terms of interpretation, you total the value between the fasting and the post stimulation value, and if it's more than equal to 5, it is strongly suggestive of type 1 diabetes. If it's between 3 to 5, it is suggestive of type 1 diabetes. Again, most likely to be the same. If it's between 0 to 3, it is unlikely to be type 1, but these patients should be on close follow-up. And both these groups, you should have low threshold for using insulin, especially for this group where you consider using basal bolus insulin. And if the value is 0, it is not type 1, it is more likely to be type 2 or any other form of diabetes. So this is something, like I said, from our own research, but again, be careful before you interpret this, because this is not a published data. We are actually doing a retrospective study on this, and we should be publishing this very soon. So to summarize and to give you some take-home messages about insulin resistance, the markers for insulin resistance, the best marker for insulin resistance is actually metabolic syndrome. right? So your central adiposity, if you have acanthosis nigricans, that's all you need, right? You don't need any complicated and very expensive test. It is mainly useful for research. For all practical purposes, clinical and surrogate markers are very useful. And amongst the surrogate marker, triglyceride levels along with presence of non-alcoholic fatty liver disease is a very good marker for insulin resistance. And of course, if you talk about gold standard, hyperinsulinemic euglycemic clamp is the gold standard for insulin resistance. Let's talk about insulin secretion. And insulin reserve testing is something that we do, which find more useful. We talked about C-peptide and stimulated C-peptide. Remember, C-peptide is a surrogate marker of insulin release. So instead of measuring insulin directly, it's better to measure C-peptide. And of course, mixed meal stimulation is very easy to perform. You just need Ensure Plus powder, which is simple, easily available. And this is a good test to, it's a very useful test for patients with ketosis prone diabetes, where you cannot differentiate between type 1 and type 2, and you want to take a call whether to treat this patient for a long time on basal bolus insulin or insulin pump versus treating the patient on basal plus OAD or OADs alone. So this is where these tests could be really useful. So I thank you all for patient listening, and if you want more, all these things on a question answer format as a notes thing, we have this website called endocrinology.co.in. It's a kind of a digital garden for endocrinology knowledge. So, it's something you can find it useful. Thank you.